Bismillah ar-Rahman ar-Rahim. Monitoring of the acid base. When we monitor this compartment, the extracellular compartment and the blood, we usually start by monitoring a lot of items. The first one, which is the pH. pH, this means that the power of hydrogen ion. This power of hydrogen ion, or this pH, starts with the Henry law and the Henderson-Hasselbalch equations. Came from the dissolved carbon dioxide. Carbon dioxide dissolves by a dissolution factor, which is 0.03, to give you carbonic acid. So the value of carbonic acid equals 0.03 multiplied by the partial pressure of carbon dioxide, which is 40. So the carbonic acid present in this case will be 1.2 millicarbon per liter. Part of it dissociates into hydrogen ion and the bicarbonate. And this part, dissociated part, is dissociated by certain constant, by certain value. This constant is what we call dissociation constant. Here comes the Henderson equations. So the pH, again, this is the power of the hydrogen ion, or the negative expression of the logarithmic measures of hydrogen ion. The pH usually, when you look at that, this is Henderson-Hasselbalch equations, because the pK, which is dissociation constant of carbonic acids, in addition to plus the molarity factor, and this gives you the value 6.1. But this is a logarithm of bicarbonate and carbonic acids. Usually the bicarbonate is 24, carbonic acid that I have mentioned before that it is 1.2, so the value is 20. Logarithm of 20 is 1.3. When you add this together, so the pH is 7.4. If it is more than 7.4, it is alkalemia. If it is less, it is acidemia. Again, we have to look again back. The pH depends on bicarbonate and carbon dioxide. This is the good relation between the two. Increase in the carbon and the bicarbonate is associated with increase in the carbon dioxide and a compensating mechanism so as to keep the pH close to the normal. Decrease in the bicarbonate would be associated with decrease in the carbon dioxide in order to keep this pH normal. The pH of the cell itself or the cell organism differs from organelles to organelles, but collectively the cytosol is 6.8. Again, when you look at the pH equals bicarbonate of a carbon dioxide, I've mentioned it before. So the value of the pH depends on the bicarbonate concentrations and the partial pressure of carbon dioxide or dissolved carbon dioxide, which is carbonic acid, or the partial pressure of carbon dioxide. This is the Henderson-Hasselbalch equation. So when we come to Stewart, we found that this is the bicarbonate equals strong ion differences minus the total weak acid. So the pH depends on the change in the pH or the change in the hydrogen ion concentrations depends on the strong ion differences, total weak acid, partial pressure of carbon dioxide, and these are the three independent factors which determine the hydrogen concentration of the pH. So I think when we study it in this way, we can take the advantages of Anderson in addition to the Stewart, and we can have a good look at the ABG. The amount of the concentrations of hydrogen ion in the extracellular fluid is about 40 nanomole per liter, but it is very high. It is more high in the intracellular fluid. This is about 80 to 100. In urine, the urine concentration is very high for sure. The gastric acid concentration is very high. Again, this is a pH, meaning the power of hydrogen. It is the negative logarithm again, and we have to take care that this is it is not has no relation. So it's a relation to the concentration of hydrogen ion is not so simple. If you want to know the relation between the pH and the iron concentration, this is a change in the hydrogen concentrations by a factor 2 causes a pH change by 0.3. We know that the pH is 7.4. This means that the concentration of hydrogen is about 40 nanomoles. So this useful relationship holds because the logarithm of 2 is 0.3. So doubling or halving the hydrogen ion means a change in the pH by 0.3. For example, this is if the pH is 7.1, it is less than 7.3 by 3, and we know that that's 40, this 40 nanomole multiplied by 2, make a change by 0.3. So in this case, the pH, the hydrogen concentration increased, doubled. Instead of being 40, it became 80. Usually this is the pH, the normal pH. Increasing the pH means alkalosis or alkalemia. So you should take care of this. This is will be associated with variable clinical manifestations, and finally death. This is a hard number. You should never ever come to this number. You should treat the patient before you reach to this number 7.8. Same thing for decrease and the pH will be is an acidemia, or the number. This number also is a fatal number 6.8. Which is best to use the pH or hydrogen concentrations. We are familiar now with the pH is not hydrogen concentration because this is the traditional one, and it is related to the activity and not the concentrations, and this is what is measured usually by the electrode. Disadvantage is that it does not give you a value, an accurate value of the hydrogen concentrations, and it's difficult to learn, but you should be familiar. When you measure the APG, you measure the APG according to the temperature of the patient, or what we call pH state, or what we call alpha state. This alpha state, the pK of the acidic intermediates usually is less than 4.6, and that for the alkali intermediates is more than 9.2. At 37 degrees centigrade, the cytosol pH, as we mentioned before, is 6.8. Where the pK of all intermediates at that time is usually 1. This means that all intermediates are ionized, completely ionized. This means that the hydrogen ion equals the hydroxyl groups, or all of it are completely ionized. This is very important because the content of the cells, if it is not ionized, this inorganic material will escape from the cell. So that's why this pH at that temperature is called the pH of neutrality. The pH of neutrality varies directly with the temperature. This is due to the presence of a pFA with certain characters. Its pK equals that half of the pK of water. Half pK of water, you know that the pK of water is 14, and the pH of water is 7. So this is close to this pH of neutrality. In addition to the presence of a large amount of bicarbonate protein, which is alpha imidazole ring in large amount, in addition to the phosphate, all of these they make the pK close to 7, and so which changes with the temperatures. So at every temperature, the pH is a pH of neutrality to keep the cell alive. So at any body temperature, so all the intermediates will be fully ionized and trapped within the cell. So alpha or pH state, since both the pK and the pH varies directly with the temperatures, and since the value of the APG at 37 degrees is known for all of us, so it is better to read that the APG at 37 degrees better than correction of the temperatures to different temperatures of unknown reference value. What about the pH of the solutions? If you look at this is the pH of solutions. If the solution is salt, is formed of strong base and strong acid, like sodium chloride. This dissociates completely into sodium and chloride, and so the pH is that of water, which is 7. But when we look at the strong base and weak acid, like sodium acetate or the sodium lactate, so this is a pH, and this will dissociate into sodium and lactate, and lactate will form lactic acid in addition to hydroxyl groups. So this is give you alkaline media. The same thing for weak base and strong acid like ammonium chloride. This ammonium chloride is an acidic. It will give you a hydronium, so the pH is less than 7. That's it. Again, this is sodium acetate. Look at it, sodium and acetate. Acetate will dissociate with water to give acetic acid hydroxide group, which is an alkaline. Ammonium chloride, ammonium chloride. So the ammonia will react with water, dissociate with water to give you ammonia and hydronium. This is acidic. Sodium chloride is pH 7. Dissociates completely into sodium and chloride. Sodium sulfate also pH is 7 because dissociates completely into sodium and sulfate. You should keep it in mind while you are dealing with that. And this is another important golden rule to be memorized by heart. Change in the partial pressure of carbon dioxide 10 millimeter mercury up or down will be associated with the change in the pH 0.08. So when you say this retention of carbon dioxide by 10, instead of being 40, it will be 50. This means that there will be some sort of acidosis, respiratory acidosis, and the pH will drop. Instead of being 7.4, it will be 7.32, and vice versa. Same thing which be for the bicarbonate. Change in the bicarbonate up or down 10 milliequivalent per liter will be associated with change at the pH 0.15. When there is some sort of retention of carbon in bicarbonate, instead of being 24 to be 34, this means there's some sort of alkalosis. And the pH, instead of being 7.4, it will be 7.55. And the reverse is true. So this should be memorized while you are solving the problems of ABG. When you look at the ABG, it is normal. It's good. Normal means that this is a normal. Or it may be normal due to compensation. This patient is having metabolic acidosis, so it's compensatory respiratory alkalosis, and the pH is normal. So normal does not mean that the pH is normal. You have to look at and interpret what's meant by it. Or it may be due to mixed changes. A patient with diabetic ketoacidosis, he's an acidotic, but at the same time started to vomit. So there is retention of bicarbonate. So when you look at the pH, it is normal, but it is due to two pathology. One, which is high anion gap ketoacidosis, and in addition to this, normal anion gap alkalosis due to vomiting. This is important. Again, when you look at the pH, you have to consider that the pH is the result of a change of two things. It's bicarbonate and carbon dioxide. And you have mentioned before, change in carbon dioxide, increase in carbon dioxide, and bicarbonate will be associated with increase in the carbon dioxide to keep the pH normal. Decrease in bicarbonate will be associated with decrease in carbon dioxide to keep the pH normal. Bicarbonate, this is changes due to addition of acid or loss of kidney or loss of gastrointestinal tract or the formation by the kidney under the effect of the partial pressure of carbon dioxide, acidosis, angiotensin II, hypokalemia, aldactone, and cortisol. So these are the factors which determine the value of bicarbonate. At the same time, the carbon dioxide is determined by the production from the cell or the ventilatory. There's a hyperventilation to wash out or hyperventilation to retain it. So this is very important while we are dealing with the pH. So the pH is the result of this of the changes in these two items. Well, look at that. This is a low pH. Low pH. This is acidemia. So this is acidemia. Well, may be due to metabolic problems or respiratory problems. Metabolic problem, this is acidemia. This means that there is a decrease on the bicarbonate. As I've mentioned, decrease in the bicarbonate will be associated with decrease in the carbon dioxide or washout of carbon dioxide. So decrease in the bicarbonate, this may be due to increase in the chloride. This is the electroneutrality, or this is the increase in the chloride due to what we call some sort of diarrhea. There is a loss of bicarbonate and at the same time retention of chloride. Increase in the albumin will be associated with decrease in the bicarbonate. Increase in the phosphates will be associated with decrease in the bicarbonate, or an acid load, as ketoacidosis or something like that, or water excess, some sort of dilution. So this is a problem. So you have to take care. So this is a metabolic acidosis in which there is a decrease in the bicarbonate, and at the same time this compensatory wash out of carbon dioxide. Maybe respiratory. This is a low pH. Maybe respiratory. This means that respiratory. This is respiratory acidemia. This is increase in the carbon dioxide. Increase in the carbon dioxide will be associated with increase in the bicarbonate as a compensation. So this is the pH. This may be metabolic or respiratory. Metabolic, this is decrease in the bicarbonate, will be associated with washout of carbon dioxide, decrease in carbon dioxide. Respiratory, the respiratory acidosis is mean increase in the carbon dioxide with concomitant increase in the bicarbonate as a compensatory mechanism. Look at this. This is a high pH. pH is more than 7.4. This is a metabolic or respiratory alkalemia. So this is a metabolic alkalemia. This means that bicarbonate is high. Bicarbonate, large bicarbonate, compensatory increase in the carbon dioxide. As I've mentioned before, increase in the bicarbonate. This is maybe due to increase. This is decrease in the chloride. This is a normal and NGAV. This is loss of chloride, maybe through vomiting, will be associated with hypochloremic and metabolic alkalosis, or decrease in the albumin will be associated with increase in the bicarbonate, and the decrease in phosphorus will be associated with increase in the bicarbonate, or decrease in the acid load, or water excess, or hypokalemia. All of these will be associated with increased stimulations of this is bicarbonate increase due to the stimulations of carbonic anhydrase, which leads to increase in the bicarbonate. Or this may be respiratory. This is respiratory alkalosis. So this means that there is a washout of carbon dioxide. Washout of carbon dioxide, decrease in carbon dioxide will be associated with decrease in the bicarbonate as a compensatory state. So this is pH, maybe normal, maybe high, maybe low, and you have to interpret it what it is. Thank you.